Hey class, I hope you're doing well. Welcome to this next session titled Global Surgery. This is an important topic in global health as we continue to improve the quality of surgeries that are administered around the world. This next presentation is going to be different from the other ones because it's been put together by Professor Abebe. It's going to be a voiceover, but the actual presentation was put together by Professor Abebe. Professor Abebe is the dean, founding dean of the medical school here at UGHE. He's also the current deputy vice chancellor in charge of academics and research affairs. He's a professor of surgery and he's done a lot of work, including many publications on this topic in the region and around Africa in general. So please enjoy this session.
Welcome to Introduction to Global Surgery. The objectives of this video are to help you understand the definition and history of the global surgery movement, to identify the relevance of the Lancet Commission on Global Surgery key messages and indicators including the National Surgical Obstetric and Anesthesia Plans, and to analyze the importance of the development of broad-based health system solutions to address the lack of access to safe surgery and anesthesia. Global surgery is the term describing a rapidly developing multidisciplinary field aiming to provide improved and equitable surgical care across international health systems. It is the field of study, research, practice and advocacy within global health working towards the attainment of better health outcomes and health equity through timely access to safe surgical, anesthesia, and obstetric care throughout the world. The areas involved in global surgery are broad, including research, data, prevention of surgical diseases, education, advocacy, volunteerism, and many more. Let's take a look at the evolution of global surgery. For too long, the global health movement has failed to count surgery as an integral part of public health. Prevailing wisdom dictated that surgical care is expensive and not cost-effective, its delivery of care too complicated, and the surgical disease burden is too low. It requires highly trained personnel and advanced health infrastructure. This is despite the fact that lack of surgical, anesthesia and obstetric care is responsible for approximately 18 million preventable deaths every year, which is more than 4 times the combined mortality due to HIV, tuberculosis and malaria. Besides high mortality rates, surgically treatable conditions make up 28 to 32% of the global burden of disease, ranging from congenital malformations to obstetric complications, from malignancies to cardiovascular disease, and from road traffic injuries to violence. In 1980, former Director General of the World Health Organization, Dr. Halfdan Mahler brought disparities in access to and quality of surgical care to the attention of the world. In his address Surgery and Health for All to the 12th Biennial World Congress of the International College of Surgeons, he said the vast majority of the world's population has no access whatsoever to skilled surgical care, and little is being done to find a solution. I beg of you to give serious consideration to this most serious manifestation of social inequity in healthcare. Unfortunately, this moral call for action did not bring the needed paradigm shift, with surgery consistently being considered as too expensive and too complex to scale up on a global level. In 2008, Paul Farmer and Jim Kim published a paper with non-surgical view of global surgery. This paper, entitled Surgery and Global Health, A View Beyond the OR, called for increased attention and awareness of surgeons and policymakers about surgery as a vital component of global health, and coined surgery as the neglected stepchild of global health. In January 2014, during the inaugural Lancet Commission on Global Surgery meeting, Dr. Jim Yong Kim, the former president of the World Bank, described surgery as an indivisible and indispensable part of healthcare.
Greetings and welcome to the inaugural meeting of the Lancet Commission on Global Surgery. In 2008, Paul Farmer and I published a paper which described surgery as a neglected stepchild of global health. We've seen modest progress since then, yet still an estimated 2 to 3 billion people are shut out of the operating room. The world's poorest countries are home to 70% of the world's people, but only a quarter of operations happen in the developing world each year. The poor suffer because of a shortage of skilled personnel, inadequate infrastructure, and a pay-as-you-go approach to financing surgical care. I urge you to challenge this injustice and to build a shared vision and strategy for global equity in essential surgical care. You can make the case that surgery is an indivisible, indispensable part of healthcare. To accomplish this, it's important to build on some impressive developments. For example, the Arvind Eye Hospital in India has taken cataract surgery to the masses at low cost and with extremely impressive outcomes. The first surgical residents begin their hands-on training at the University Hospital of Mirebalais in Haiti, a collaboration between the government and partners in health. And Atul Gawande and his colleagues have done pioneering work on safe surgery checklists. Working with the WHO, the World Bank Group has set 2 global targets for universal health coverage by 2030. First, no one will fall into poverty because of out-of-pocket healthcare expenses. And second, at least 80% of the poor in developing countries will have access to good quality, essential health services. I hope the Commission will also agree on time-bound targets to measure progress on effective coverage of essential surgical interventions. We have high expectations for your work. You can accelerate progress in universal access to essential surgical care and help to achieve universal health coverage in a generation. Together, we can help millions of people lead healthier, more productive lives. Thank you very much and have a great meeting.
In 2014, a systematic review on cost-effectiveness of surgery in low- and middle-income countries was published in the World Journal of Surgery. The article compared the dollars spent per daily averted in low-resource settings. The results showed the basic surgical interventions, such as cataract surgery, male circumcision, hernia repair, cleft palate repair, basic trauma surgeries, are more cost-effective compared to other public health interventions, such as oral rehydration therapy, breastfeeding promotion, and antiretroviral therapy. This led to the conclusion that simple surgical interventions, both life-saving and disability-preventing, should be integrated in public health policies and be accessible at district hospitals, further debunking the previous myth of the relative high costs of surgical care. Since then, more publications began to emerge. 2015 was a pivotal year for global surgery. For the first time, a surgery-dedicated volume in the Disease Control Priorities 3rd edition by the World Bank Group presented surgical care as cost-effective interventions to address the global disease burden. The Lancet Commission on Global Surgery mapped the global state of access to surgical and anesthesia care, which they published in their report Global Surgery 2030, Evidence and Solutions for Achieving Health, Welfare and Economic Development, providing the international community with the needed rationale for addressing global surgical care. The 68th World Health Assembly Resolution, the WHA 68.15, was also adopted. The resolution strengthening emergency and essential surgical and anesthesia care as a component of universal health coverage put the surgical foot in the global health door. In 2017, the 70th World Health Assembly marked another big step towards achieving safe surgical care for all, with multiple stakeholders including member states, NGOs and academic institutions further drawing the attention to global surgery. Zambia, Ethiopia, Tanzania and Rwanda were the first countries to announce their national surgical obstetric and anesthesia plan a framework for integrating surgical care in a country's health agenda. The Lancet Commission of Global Surgery clearly laid out its vision for universal access to safe, affordable surgical and anesthesia care through its 5 key messages, 6 indicators, and the need for the national surgical obstetrics and anesthesia plans. Key message 1. 5 out of every 7 people, translating to 5 billion people in the world, do not have timely access to safe surgical care when needed. Access is worst in low-income and lower-middle-income countries, where 9 of 10 people cannot access basic surgical care. Key message 2. 143 million additional surgical procedures are needed in low and middle-income countries each year to save lives and prevent disability. Of the 313 million procedures undertaken worldwide each year, only 6% occur in the poorest countries, where over a third of the world's population lives. Low operative volumes are associated with high case fatality rates from common treatable surgical conditions. Unmet need is greatest in Eastern, Western, and Central Sub-Saharan Africa and South Asia. As a result, by 2030, 2.28 million additional surgeons, anesthesiologists, and obstetricians are needed to provide the additional 143 million procedures needed per year. Key message 3. Each year, 81 million people face catastrophic health expenditure related to surgery and anesthesia care. 33 million are due to payment for surgery and anesthesia care. 48 million cases are attributable to the non-medical costs of accessing surgical care. A quarter of people will incur financial catastrophe as a result of having a surgical procedure. The burden of catastrophic expenditure for surgery is highest in low-income and lower-middle-income countries, and within any country, the burden is heaviest on poor people. Key message 4. Investing in surgical services is affordable, saves lives, and promotes economic growth. To meet present and projected population demands, urgent investment in human and physical resources for surgical and anesthesia care is needed. If low and middle-income countries were to scale up surgical services at rates achieved by the present best-performing similar countries, 2/3 of countries would be able to reach a minimum operative volume of 5,000 surgical procedures per 100,000 population by 2030. Without urgent and accelerated investment in surgical scale-up, these countries will continue to have losses in economic productivity. To support this surgical care scale-up globally, an investment of only $350 billion can preventing a potential loss of $12.3 trillion in economic growth in low and middle-income countries. Key message 5. Surgery is an indivisible, indispensable part of health care. Surgical and anesthesia care should be an integral component of a national health system in countries at all levels of development. Surgical services are a prerequisite for the full attainment of local and global health goals in areas as diverse as cancer, injury, cardiovascular diseases, infections, reproductive, maternal, neonatal, and child health. Universal health coverage and the health aspirations set out in the post-2015 Sustainable Development Goals will be impossible to achieve without ensuring that surgical and anesthesia care is available and accessible, safe and timely, as well as affordable.
Lord William Tangi, Professor John Miara, Dr. Walt Johnson, colleagues, distinguished guests, ladies and gentlemen, greetings from Geneva, and thank you for the invitation to speak to you today. And I'm really sorry I can't be with you in Dubai. As you know, surgical, obstetric, and anesthesia care is an essential part of every health system. No country can achieve universal health coverage unless its people have access to safe, timely, and affordable surgical services. 9 of the 13 targets in SDG 3 will never be achieved without improved surgical care. And yet, globally, 5 billion people and 90% of the world's poor lack that access. It's therefore vital that countries invest in surgery. WHO estimates that globally investments of $350 billion are needed between 2016 and 2030 to build appropriate surgical systems. Failing to make those investments could result in losses of more than $12 trillion. As part of WHO's transformation, we will be engaging in much more strategic policy dialogue with countries to identify health systems gaps, ensuring that all countries invest in surgery on the road to universal health coverage. Thank you for your commitment to this very important issue and for your support as we work together to promote health, keep the world safe, and serve the vulnerable. I thank you.
The Lancet Commission published 6 indicators in the Global Surgery 2030 report to measure, evaluate, and monitor surgical systems, which, if used together, will allow for mapping a country's surgical care system and highlighting the barriers to access. These 6 indicators are: access to timely essential surgery, surgical, anesthesia and obstetric care provider density, surgical volume, perioperative mortality rate, risk of catastrophic expenditure due to need for surgical care, risk of impoverishment. The first indicator is 2-hour access to surgical care. This indicator measures the percentage of population with theoretical 2-hour access to the bellwether procedures. The bellwether procedures are caesarean section, emergency laparotomy, and open fracture repair. District hospitals that are able to perform the bellwether procedures function at a level of complexity that enables the delivery of other related surgical care. Access is defined by the Lancet Commission on Global Surgery as physically available in a timely manner, having the necessary capacity, being of sufficient quality and safety, and being affordable. By 2030, the Lancet Commission aims to have 2-hour coverage of at least 80% of the population. The second indicator is surgical specialist workforce. This indicator measures all surgeons, anesthesiologists, and obstetricians per 100,000 population. The Lancet Commission proposes the goal of reaching 100% of countries with at least 20 such professionals per 100,000 population by 2030. The third indicator is surgical volume. Surgical volume is measured as the number of operations done in an operating room per 100,000 population per year. Similar to workforce, increasing the number of interventions beyond a threshold of approximately 5,800 procedures per 100,000 population reduces the cost effectiveness and increases unnecessary interventions and risks of surgical care. As a result, the Lancet Commission has set the target of 5,000 procedures per 100,000 population by 2030 for all countries. The effectiveness threshold, above which the decline in number of deaths reaches a plateau, comes down to approximately 5,000 surgical procedures per 100,000 population. The fourth indicator is post-operative mortality rate. This indicator includes all-cause mortality prior to discharge of patients who received surgical care in an operating room. It is the number of patients divided by total number of procedures. It is used to assess the safety and quality of the intervention in itself and post-operative management by the respective facilities. To monitor, evaluate and address post-operative rate, a 100% tracking rate is aimed for by 2030. The last indicators are both related to expenditure. Catastrophic expenditure measures the protection against catastrophic expenditure from out-of-pocket payments for emergency and essential surgical care. Impoverishing expenditure measures the protection against impoverishing expenditure from out-of-pocket payments for emergency and essential surgical care. Targets of 100% protection against both indicators are set for all countries by 2030. In order to achieve the targets of these 6 indicators, countries must work together towards universal access to safe, timely, and affordable surgical obstetric and anesthesia care. The Lancet Commission on Global Surgery introduced a framework for national surgical, obstetric, and anesthesia planning, known as NSOAP. NSOAP is a framework that offers a systematic approach to strengthen surgical systems, covering 6 domains of the health system: infrastructure, service delivery, surgical workforce, information management, financing, and governance. To date, several countries have developed and launched NSOAPs. Over the past years, Zambia, Nigeria, Madagascar, Tanzania, and Rwanda have completed plans through the Ministry of Health-led approaches. Senegal began their national plan prior to 2015, and is currently in the 5th year of implementation. Ethiopia independently adopted a national surgical plan, saving lives through safe surgery, also known as the SALTS. 10 additional plans are underway, with many countries who have expressed commitment to the development of NSOAPs. Latin American countries have begun plans for national surgical planning with a forum that bring together countries with interests on regionalizing the NSOAP model for South America. The 3 Delays framework is a model used to better understand the factors influencing access to surgical and anesthesia care and solving the problems thereof. First delay, delay in deciding to seek care. This delay is a result of cultural beliefs, poor perception of quality of care, lack of awareness of available services, geographical restrictions, financial limitations, and societal inequalities. Second delay, delay in reaching care. Poor transportation and road infrastructure, costly transportation services, challenging geographical terrains, and poor organization of the relevant healthcare facilities promote and sustain the delay in reaching surgical care. Third delay, delay in receiving care. Inadequate referral systems, poorly trained health workforce, poor facilities, inadequate in-hospital care, and lack of essential medicines are a final barrier in accessing surgical care. Recently, the fourth delay, delay in staying in care, is being defined. In order to tackle the issues affecting access to emergency and essential surgical care, it is important to reduce all forms of delays, for which a strong pre-hospital network, comprehensive community participation, emergency transportation, infrastructure, and resource investment will prove crucial. Moreover, through advocacy and education, individuals and international organizations are able to positively affect health outcomes indirectly. The world at the present moment suffers from extreme shortage of healthcare professionals currently. A shortage of 7.2 million health workers exists. which is estimated to rise up to 12.9 million by 2035 as a result of the rapid increase in the world population. Besides absolute shortages, inequity exists between and within regions. Africa only has 2 to 3% of the health workforce, while bearing 24% of the global burden of diseases. Similarly, Southeast Asia has 12% of the health workforce, yet bearing 30% of the global burden of disease. In terms of surgical workforce, relative shortages pose an even bigger problem. For example, in East Africa, there are less than 2.5 fully trained surgeons per 1 million population, compared to 56.8 per million in the United States of America. Africa holds only 3% of the world's 500,000 obstetricians, contributing to the global preventable maternal mortality rate of 300,000 women during childbirth. To make up for the lack of surgical services, many countries in the developing world have adopted the task shifting model. Task shifting is defined as extending the scope of practice of existing cadres of health workers to allow for the rational redistribution of tasks among the health workforce in order to make better use of human resources and ease bottlenecks in the service delivery system by delegating certain medical responsibilities to less specialized health workers. 25 of the 47 sub-Saharan African countries have been utilizing these mid-level workers to provide surgery and anesthesia care. The social determinants of health are the conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems shaping the conditions of daily life, including economic and social policies, development agendas, social norms, and political systems. Shaped by an unequal distribution of money, power, and resources at global, national, and local levels. The social determinants of health are mostly responsible for health inequities seen across the globe. The social determinants of health has been well established in public and global health, yet, this concise and informative framework has not been widely used to discuss access to surgical and anesthesia care. They can be summarized as the 4 Ss: systems, space, staff, and stuff. Some of the actual determinants of surgical care include misdiagnosis, late or no diagnosis of surgically treatable conditions, and preventable emergency conditions. Deaths are promoted by poverty, lack of education, and general lack of access to healthcare. Gender and age contribute to disparities in accessing emergency and/or surgical care, with women and children disproportionately discriminated against in some cultures and societies. Surgical health outcomes are influenced by political decisions. War promoting food maldistribution, population displacement, health systems disturbance, and by a country's policy decisiveness locally and globally. Provision of adequate equipment, including medicines, blood, tissue components, infrastructure, and human resources, both in quality and quantity. What are the next steps in global surgery? To achieve safe and affordable surgical and anesthesia care for everyone, everywhere, whenever needed, multidisciplinary efforts are needed on all levels, with a mixture of bottom-up and top-down involvement, dynamic stakeholder engagement, and leadership by ministries of health. The international community should transition to a coherent movement, recognizing and including surgery and anesthesia as integral components of universal health coverage and primary care, in order to strengthen overall public health. Besides international involvement and policy making, countries will have to address surgical systems on a country level through the creation of NSOPs. The creation of such plans involves a baseline assessment of all health facilities using the surgical indicators at facility level as well as at the national surgical health system level. In terms of capacity building, both a national and international approach is necessary. Nationally, countries will have to increase the number of locally trained health workers through the establishment of affordable and adequate training institutions, and reprioritizing government budgets with a focus on healthcare and education. Internationally, North-South and South-South collaborations allow for skills and knowledge exchange, and increased training and funding opportunities through innovative programs. Such equity-based partnerships ought to be established with due diligence, by choosing partners wisely and with transparency, as well as monitoring and evaluating them regularly. A sustainability framework built into such programs is also needed. Similarly, building and rebuilding infrastructure in the public sector, with an emphasis on the district hospital level, ought to be prioritized. To make surgical care financially accessible for patients, governments need to introduce universal health coverage packages with financial risk protection, including basic surgical and essential surgical care. Universal health coverage can only be achieved and implemented effectively if equity mechanisms are strengthened. This requires identifying factors predisposing, precipitating, or perpetuating people to reduced resilience and health risks. Raising awareness about the importance of surgical care is an essential part of health systems. Sustained advocacy is needed to hold international and national leaders accountable for the inequities in accessing surgery and anesthesia between and within regions and countries. If we are to reduce the more than 17 million preventable deaths due to lack of surgical care every year, and in turn to attain the Sustainable Development Goals by 2030, an integrated and collaborative approach is urgently needed. Thank you. Please join us on our journey to achieving surgical care for all. If you have any questions, please do not hesitate to contact Professor Abebe Bekele, Deputy Vice-Chancellor of Academic and Research Affairs, Dean of School of Medicine at University of Global Health Equity.